talking to you today about environmental emergencies. So the title of my presentation is called Fire and Ice. I also want to give a thank you to Dr. Silverman, who's the Vice Chair of the Department of Emergency Medicine at Morristown, for letting me borrow some of his slides. Next slide. Okay, so this is going to be a case and followed by a discussion method to the lecture. So at any point, just feel free to interrupt with any questions, comments, answers even. It's a free-for-all, so it doesn't affect me in terms of what I'm presenting to you guys. So the first case, we'll get into it, is a 22-year-old male who's running a half marathon in July, and he's brought into the ED complaining of cramps and vomiting. Oh, next slide. I keep trying to move it myself and I realize I don't have control. Okay, so he's alert and oriented to person and place, but he's confused to the details and time. On vitals, he's tachycardic, his heart rate is 130. He's tachypnic, his respiratory rate is 22, and his blood pressure is 100/60, which is slightly on the lower side for his age. His skin is dry, his heart is tachycardic but otherwise regular, his lungs are clear, and his belly soft and untender. Shelley, are these the new or old slides?
These were the new ones that I got from you last night. Are they not new enough? Because I could change and go into the Google Doc if you want.
We'll continue with it, but I think, okay, I think that they're the old ones, but it's all right. I'll just go over.
I was like, I could totally switch it. You want me to?
Yeah, well, that's because I added some slides, so
yeah.
I don't know if they're in there. I don't know if you can check if they're in there.
We'll just do it from Google. Don't worry about it.
Thank you.
Yeah, of course. So you guys, this is called impromptu. We make things happen. All right. And present. Okay. And now I have to go to the Zoom. No. And share screen. This one. Okay. Present. Does it look good?
Yeah.
Okay. So.
Yes. Okay. I think this is it. Yeah. Thank you.
No problem.
Okay. So, the guy running a marathon in the middle of the summer, what are the labs that we want to get on him? So you want to do a metabolic panel to check his electrolytes. So as you see, his sodium is 155, which is high. You have to keep it to consideration why it's high. Is it hypovolemic, euvolemic, hypervolemic, hypernatremia? So considering his history where he's been running, sweating a lot, it's the middle of summer, probably not drinking enough water, your clinical suspicion would be that it's euvolemic hypernatremia. His potassium is 4.0, which is within the normal range, but the reason why we include it here is because that's something that you would look for specifically on his blood work to make sure it's normal. And the reason for that is explained in the next test, which is the CPK, which is 5,000. You're concerned for that, you get that because you're concerned for rhabdomyolysis. So with the breakdown of muscle and cells, you get increased potassium as well. Thankfully, his is normal. And then you can also get a urine analysis for any evidence of myoglobinuria, which he has because he has dark red tinged urine, but no RBCs in there, red blood cells. His specific gravity is also elevated at 1.2, meaning that he's dehydrated. Oh, next slide. So this brings us into temperature-related illnesses. The two most important ones for the emergency department is heat exhaustion versus heat stroke, and differentiating between them because one is an emergency, whereas the other one isn't to the same degree. But you also have things such as prickly heat and heat cramps, which we'll go into. Next slide. So what are the heat loss mechanisms that our body has? There's four major ones. The first one is radiation, which is heat loss by electromagnetic waves, which accounts for about 2/3 of how heat is lost at lower ambient temperatures. And then you have evaporation, which is the dominant mechanism for how heat is lost at higher temperatures. And this usually consists of you sweating, and the sweat turns into vapor through evaporation. There's also conduction and convection. So conduction is transfer of heat by direct contact with another object. So that's when you warm up the stove and then you put a cold pan onto the stove and the pan heats up. So the pan heats up through conduction of that heat from the stove to the pan. And then you have convection as well, which is heat lost to circulating air. Next slide. So it takes about 1 to 2 weeks for your body to acclimate to a change in temperature. During exercise, you have about 20-time increase in heat generation in your body. And there's certain risk factors that can make you more prone to have a heat-related illness. For example, one of the major ones is any cardiac disease. So if there's any reason why your cardiac output isn't able to keep up with the demand, just because with exercise you have decreased demand, or with any heat, you have increased demand on your body to increase the blood flow to evaporate that heat and to lose it through sweat. So if you can't keep up with the increased cardiac output, then you can't keep up with heat loss, meaning your body temperature goes up. There's other things as well, such as medications, whether they're prescription-based or non-prescription-based. So you have beta blockers, anticholinergics, diuretics, and even alcohol. Any mental status abnormality as well. For example, elderly patients are a lot more prone to having heat-related illnesses, just because you and I can think, okay, well, it's a hotter day outside. Even though I may not be thirsty, I should increase my water intake to stay well hydrated. Whereas an elderly person, whether it's because of dementia or whatever else it may be, may not connect the two. So they're at increased risk of a heat-related illness. Something else is intoxications, whether that's with alcohol or drugs such as cocaine, amphetamines, ecstasy. These are all agents that are sympathomimetics, so they increase your body's natural heat generation. Next slide, please. Okay, so you have minor heat illnesses such as heat exhaustion or heat prostration. So this is primarily a problem with volume depletion and electrolyte abnormalities that you lose through sweating. So typically it can be anywhere from heat cramps, edema. Sometimes you can pass out briefly from it, and you can have a sun rash, which is what the prickly heat refers to. So you want to treat this and treat the underlying cause of it, just because it can become more deadly and lead to heat stroke. And so what differentiates heat exhaustion from heat stroke primarily is that there's no end organ dysfunction, and more commonly, there's no central nervous system involvement. Next slide. So prickly heat, like I said, is a sun rash that that I was referring to. I think we've all gotten it at some point in our lives. It's just these reddish, bumpy, itchy areas of a rash on your body, and it's usually during hot, humid environments. So what happens is you start sweating, but it's such a humid environment that the sweat can't evaporate, so that the sweat builds up on your skin and it clogs the sweat ducts. They become blocked. The treatment for it is to just rest in a cool place and keep your skin dry and clean. Next slide. And then there's heat cramps, which again, I think we've all gotten these as well. And these are just involuntary painful muscle contractions. So what you can do for these is you can just rest, stop the activity that you're doing, rehydrate with electrolyte containing beverages. You can massage the muscle, and you can also stretch. In severe cases, these can require emergency department visits for IV hydration. Next slide. So again, heat exhaustion, caused by you can have heavy sweating, leading to loss of fluids and salt. Your skin can become clammy, you can become pale or flushed, feel weak, dizzy, nauseous. Just stop what you're doing, go into a dry place, rehydrate, primarily through electrolyte containing solutions, just because sweat isn't just plain water, it also contains electrolytes. Next slide. And then we have heat stroke. Again, this is the heat exhaustion versus heat stroke. So heat stroke is where your core body temperature is greater than 40.5 degrees Celsius. And there's evidence of end organ dysfunction. And the hallmark of this is usually neurological dysfunction. So anything from cerebral edema, mental status changes, seizures, delirium, any bizarre behavior. Commonly, you'll have construction workers bring in one of their friends on scene because they are acting unusual and different to them. And so what you'll find out is that they're suffering from a heat stroke. Other evidence of organ dysfunction can be muscular injury, such as rhabdomyolysis or breakdown of the muscle, hepatic injury with elevated transaminases, diarrhea from vasoconstriction of the vasculature to the intestines, and then renal failure as well, resulting in decreased urine output from dehydration. Next slide. It's also important to mention, so for any, whether it's hypothermia or hyperthermia, to get an accurate measurement of the body temperature. So I think the best way to do that is through an esophageal probe to measure the body temperature of a person. But the way that we do it more commonly because of convenience here in the emergency department is you can do a rectal probe or a Foley catheter probe through the urethra. Continue with heat stroke. You have two etiologies, technically, if you want to call it that. So one is a classic heat stroke. This is typically non-exertional. Again, with my elderly example before, usually this occurs in heat waves where maybe it's children or the elderly, they don't have the same thinking where they need to keep up with hydration. They have very little sweating that's involved just because, again, they're not exerting themselves, and there's very rarely is there rhabdomyolysis involved. And then there's exertional heat stroke, going back to the construction worker example, or even a young athlete, anyone who's young, active, they're overly exerting themselves, and prolonged exposure to extremely high temperatures, causing profuse sweating. And with this, you'll commonly see rhabdomyolysis. Next slide. So how do you treat heat stroke? The primary treatment is just rapid cooling. Obviously, their body is at too high of a temperature for them. And so what you're gonna do is cool it down to normal temperature. So you're gonna do this gradually. First, you wanna start with huge fans. So we'll get big fans from environmental services and just blow cold air onto them. You can upgrade from there. Here it says ice water immersion. Obviously, we can't take our patients and just plunge them into cold water in their rooms. So what we do instead is we take ice cold packs and just place them on their axilla or under their armpits and in their groin to decrease their body temperature. And then from there, you can graduate into peritoneal lavage with cold fluids, ECMO, and even paralyze them to decrease their own generation of body heat, which can happen. And then your main goal is to get their body temperature down to 38 degrees Celsius. Next slide. All right, so that was our heat-related illnesses. This brings us to case number 2. So you have a 50-year-old gentleman. He's found unresponsive next to a bottle of alcohol in the park by police officers. They called the ambulance on him, and the ambulance gets some vital signs. He's bradycardic. His heart rate is in the 40s. His respiratory rate is very low as well. It's 10, and his blood pressure is 100/60, which is also on the lower side. His lungs are clear. His heart, aside from the bradycardia, is otherwise normal. His abdomen is soft and non-tender, and his skin is cold to touch. Next slide. So this brings us to our cold-related illnesses. So you have the localized versus systemic cold-related illnesses. Our systemic being our hypothermia versus our localized being those 4 that are listed. So within the localized cold injuries, you have 2 categories, non-freezing and freezing temperature related. So the non-freezing consists of chillblains and trench foot, and the freezing consists of frost nip or frostbite. Next slide. So this is chillblains. I think, you know, a lot of us have probably gotten this as well. This is just localized inflammation of blood vessels due to prolonged exposure to cold environments, cold but not freezing environments. So you just rewarm this, go back to a warm environment, and it should subside there on its own. Next slide. This is trench foot. So this is more of an immersion injury. So this occurs when whatever the extremity may be, whether it's the feet or the hands, typically more commonly it's in the feet. They're exposed to a wet and cold, again, cold but non-freezing environment. Most commonly it's taught to us in the homeless population, where they don't have access to change of footwear or socks. So during the winter months when it's snowy or cold outside, or even in the spring and fall when there's a lot of rainfall, their shoes may be wet or their socks may be wet and it's cold outside, and they continue to have their feet in that environment. So as you can see, it can lead to significant damage, sometimes to the point where it requires digit amputation. Next slide. So then going into our freezing injuries, this leads us to frostbite. So this is vasoconstriction that limits heat loss. This is significant vasoconstriction that happens. And so this can be due to tissue temperature that drops below 0 degrees Celsius. So the reason for the vasoconstriction is that that's one of the ways that your body decreases the heat loss, by decreasing the blood flow to that area. As you can imagine, if you decrease the blood flow, you're decreasing what the tissues need to continue surviving. So as the degrees of frostbite progress, it can lead to numbness or just lack of sensation completely, and necrosis of the skin all the way down to the bone. And that's where you see that chunk of wood appearance. You can also have blisters to the areas. There's clear versus hemorrhagic blisters. So clear is more of a favorable prognosis, whereas hemorrhagic, it indicates more of a poor prognosis, and that just is because that means that there's damage to the subdermis and it's spreading. Next slide. So most commonly it affects the distal part of the extremities, the toes and the fingers. You can also have the face affected, with most commonly the tip of the nose and the ears. High-risk groups for this include outdoor workers, elderly patients, homeless population, and drug or alcohol users as well, and psychiatric patients. So this is the degrees of frostbite. The first degree is sort of what we call frost nips, and this is just superficial frostbite, just to the superficial layer, the epidermis, and this is just erythema and edema of the area. There's very minimal pain with rewarming of this. Second degree is where you see involvement of the dermis and you have the clear blisters. Again, you still have sensation at this point. Third degree is where you go to the subdermis, and this is where you see the hemorrhagic blisters, as demonstrated here. You can still have some sensation here, but really third degree and fourth degree frostbite are pretty severe. As you can see with fourth degree, it leads all the way down to the tendons and bones to the point where you would need digit amputation. And at this point, it's painless. You have no sensation whatsoever. So you can rewarm these patients. It's not gonna do much, but they won't feel any pain as opposed to the other 3 degrees. Next slide. So what do you do for this? They're too cold, so what you're gonna do is warm them up. So you're gonna do rapid rewarming of the affected area with water at a temperature of about 37 to 40 degrees Celsius. So you wanna leave the affected extremity in there for approximately 20 to 30 minutes until you see that the tissue starts to become pliable or erythematous or pink, to the point where you can kind of guess, okay, blood flow is starting to come back in there. Obviously, you can't just submerge a person's face into 37 or 40 degree Celsius water. So for the face, what you can do is apply moist, warm compresses to the affected areas, whether it's the nose or the ears. You want to keep in mind that when you start rewarming these patients, or when you think about rewarming them, that you're able to continue rewarming them, that it's not going to be an interrupted process, because to rewarm and then to have them refreeze is going to do a lot more damage to what they already have than to just continue refreezing, to continue rewarming them. So you want to make sure that when you start the process, it's going to be a continuous process. Just as, you know, when we come in from a really cold winter day outside and we take off our gloves and our hat and our scarf and we start to get rewarmed, it is a little bit painful. And if you can imagine, for these people with 2nd and 3rd degree frostbite, it's going to be extremely more painful. So you want to make sure that you provide them with adequate analgesics or pain control for it as well. And then the other component to it is wound care. So it's going to be either local wound care versus surgical debridement, more invasive. So for local wound care, what you can do is, again, you can debride or remove any dead skin that there may be. Obviously, if there's a lot of it, it's going to need OR surgical debridement, but sometimes you can also do it at the bedside. And then you can apply antibiotic ointment just for antimicrobial prophylaxis. And then you can put some cotton in between the digits to keep them separated, and wrap it in sterile dry gauze for protection. Next slide. And then we'll get into our systemic cold-related injury, which is hypothermia. There's different degrees of hypothermia. There's mild, moderate, and severe. So for mild, it consists of 33 to 35 degrees Celsius. At this point, your body vasoconstricts, again, to decrease heat loss. You also have the shivering mechanism in place, which is your body's natural way of trying to generate heat. And then you also have a thermogenic increase in basal metabolism as well. Moderate hypothermia is 29 to 32 degrees Celsius. This is when your body starts to lose its own ability to generate heat, so you can't shiver anymore. At this temperature, you also start to get cardiac arrhythmias as well, and that's because the heart myocardium starts to become a lot more irritable at these temperatures. Some evidence of that you can see on the EKG is Osborne Waves, which we'll describe a little bit later. You can also have organ dysfunction as well as mental status changes, so they can be altered or even in a coma and have acid-base abnormalities. Severe hypothermia is a temperature of 29 degrees or less than 29 degrees Celsius. And this is where you have complete loss of any reflexes, you're in a coma, and the chances of you going into ventricular fibrillation are significantly high. And we'll go into the treatment of that later. These are Osborne waves. As you can see, it's at the J point where the ST segment is, where they come together. And it's sort of this humpback elevation of that area on the EKG. The degree of elevation correlates to the degree of hypothermia and how low their temperature is, but it won't necessarily correlate to when you rewarm them. So you shouldn't rely on that. Next slide. They're most commonly seen in the precordial leads. One thing to keep in mind is that they're not pathognomonic or specific to hypothermia. So you can see these with other etiologies, such as neurological causes, sometimes with brain bleeds. You can see them with medications, hypercalcemia. So that's also something to keep in mind, but it can be helpful when your suspicion or your clinical suspicion for hypothermia is high and you see this on the EKG, then it just kind of reaffirms your clinical suspicion. Next slide. So how do you treat hypothermia? Obviously, one of your primary concerns is the cardiovascular system because it leads to such significant and deadly heart arrhythmias. Your most common arrhythmias are going to be bradycardia and atrial fibrillation, but your most deadly arrhythmia is going to be ventricular fibrillation. And this usually occurs below 28 degrees or at severe hypothermia as it's categorized. So you're going to want to try when you have bradycardia, just reflexively, you're going to want to go to atropine or epi or dopamine, any ionotropic agent, but they're not going to work. And they're not going to work because if you think about it, you're not treating the underlying cause of what's causing this arrhythmia. So the underlying cause is the fact that they're hypothermic. So you're going to want to rewarm them. With that being said, you still need to do ACLS or advanced life cardiac support on these patients. So you're going to want to do compressions, intubate them. You can give them epi, you can shock them. So for ventricular fibrillation, what you normally do is you defibrillate. In literature, it shows that you can try one defibrillation for their VFib, but it most likely will not work. And so your next step is to continue just, resuscitating them, doing compressions while trying to just rewarm them to 32 degrees. Next step. The other huge component of it is going to be fluid resuscitation. So obviously they have decreased blood flow throughout because they're vasoconstricted everywhere. So they're usually going to be dehydrated. So you're going to want to resuscitate them with IV fluids, but at the same time, you're going to be killing two birds with one stone, or two purposes at once, which is rehydrating them with fluids, but also rewarming them with those fluids. So you're going to want to give heated IV fluids to them. Next up. And then for the systemic rewarming. So you have different mechanisms of how you can do that. You have external versus active core rewarming. So externally, you can do warm blankets, or you can do more active warming, which here in America, we have forced air warming systems, such as a bear hugger. Essentially what that is a plastic blanket that you apply over the patient, and it has like bubbles in it that you can connect. There's a port where you can connect those bubbles to a tube that goes into a machine that provides warm air to the patient. So that's one way that you can rewarm them that we commonly use here. And then for severe hypothermia, where their temperature is less than 32 degrees, you can do systemic rewarming through warm fluids, through the NG tube or through a Foley tube, where you irrigate them with warm fluids, you flush them out. You can also do peritoneal lavage, chest tube lavages, and at the most severe cases, you can also use ECMO to rewarm these patients. Next. So what do you do with these patients, especially someone with severe hypothermia? Like we said, you got to rewarm them, number one, but you're going to continue to do compressions on these patients for a long time until their body temperature is 32 degrees, right? So how do you know when do you stop those measures? So the saying goes, you're not dead until you're warm and dead. So obviously you want to make sure that you get their body temperature up to 32 degrees. But once they're there and they're still comatose, they're still unresponsive, how do you figure out whether to continue life-saving measures? It's a difficult decision, especially if you have family there just kind of waiting for you to bring this patient back to life, which is their family member to them. So there's been some predictors in the literature in terms of how to assess whether it's a meaningful recovery or not neurologically. These haven't been validated. There's a lot of back and forth as to whether these are appropriate measure outcomes, but these are the only ones that are listed in the literature and commonly throughout multiple sources. So the three of them are fibrinogen level less than 50, a potassium of less than 10, and an ammonia level of greater than 250. So usually you want more than one of those outcome measures to apply to the patient to kind of affirm that there's no meaningful neurological recovery in this patient despite them being rewarmed. Okay, so we went over heat and cold related illnesses. I'll try to make the rest of it quick for you guys. I'm sure you guys are all tired of hearing us talk by now, but I appreciate you sticking through. So this brings us to case number 3. This is a 40-year-old patient who comes in after a house fire. He's complaining of burns to the arms, chest, and face. So this is burns. These are also another huge component of ED visits and deaths, unfortunately. One of the most important things to consider right off the bat, as soon as a patient comes to you with a complaint of a burn, is to assess the degree or if there's been any inhalation injury. And the reason for that is because of airway protection. If there's any evidence of that to you, then you're going to want to consider intubation very early on because they can decompensate on you immediately. So how do you assess for that? So number one, if they come to you with a history that they've been in this enclosed space in the burning environment for a long period of time, that should make you very suspicious. They've obviously inhaled a lot of, soot in them. So that could have caused damage to their airway, whether it's upper or lower, that may not be visualized to you. So you have to keep that in mind. But there also may be visual evidence of that. So there may be burns to the face and the mouth. There may be singed facial hair or sputum that comes out with soot in it. They might have voice changes, so any stridor or a hoarse voice. If they're coughing or if they're short of breath, these should all prompt you to consider intubation in these patients or watch them very, very closely. Another major thing for burns is fluid resuscitation. So that should also be close to number one on your management for these patients. So the number one fluid for resuscitation in these patients is lactated ringers as opposed to normal saline. The reason for that is because lactated ringers is thought to mimic the fluid in the body a lot more closely than normal saline in terms of the composition of it with the electrolytes. How do we assess how much fluid we give these patients? So there's something called the Parkland formula. It's 4 cc's or mLs per kg times the percent body surface area burned. And how we estimate that we'll talk about later. But what you do is you essentially calculate that, and that's going to give you the total amount of fluids that this person's going to need over the next 24 hours. So what you do is, let's say that the person in our story it came out to 1 liter of fluids or 1,000 milliliters of fluids. So what you're going to do is you're going to divide that in half. So it's going to be 500 and 500 milliliters. And the first 500, that patient's going to get over 8 hours. And then the next 500, they're going to get over the next 16 hours. Okay? So then how do you estimate the percent body surface area to get the total amount of fluid? So in adults, we have something here called the rule of nines, just to make it more simplified in terms of memorization. It's also a part of the London Browder chart. For kids, it's a lot more difficult to memorize depending on the age. So for them, their proportions are different. Their head's a lot bigger than ours. Their torso is a lot smaller. So as you can see in the next slide, their proportions are different and their percentages are different as well. An infant versus a child versus an adult. So it's called a rule of nines because most of them are multiples of 9. So as you see for the adult, the leg, the front and the back is 9%. The torso is 18% front and back. The head is 9% in total, with 4.5% being the front and 4.5% in the back, and so on. So hence the rule of nines. So for our patient, I believe it was the face, the chest, and the arms. So that's definitely more than 20%. And the reason why I bring that up is any burns that are more than 20% in America meets criteria to transfer them to an official burn center. So not all hospitals are official burn centers. There's ones that are specialized for it. Morristown is actually not one of them. So what we do is we make sure that there's any indication for transfer. We stabilize those patients in the emergency department here, and then we transfer them to the official burn center. All right. There's two, major, I guess you can say, types or two different categories of burns. You have your significant body burns, where they can be greater than 20% or involve the perineum or the face, the digits. There's also circumferential burns in that category as well. That would be categorized as severe. And then there's minor burns. So for circumferential burns, it's important to consider compartment syndrome in them. And that's because within the muscle damage that occurs, there can be bleeding or just edema of the muscle from the burn itself, which can cause an increase in the pressure in that compartment. Specifically in the trunk area or in the torso, if that happens, as you can imagine, that pressure builds in that compartment, and it's going to make it a lot harder for your chest to rise and to expand and to be able to allow you to breathe. So it's going to mess up your ventilation or your ability to ventilate yourself. So what you can do for that is, for compartment syndrome, you have fasciotomy. Escharotomy is just more specialized. It's similar to that, just specialized for third-degree burns, essentially. So what you do is the same thing as a fasciotomy, where you would just make an incision to open up the compartments to release that pressure. Then you have minor burns. So this you can just treat locally. So you can debride any of the burned skin in that area, and then apply topical antibiotic ointment, or we have something called Sylvadine, which is similar to it, and then put a non-absorbent dressing on it. And you want non-absorbent so it doesn't stick to the area, so that it promotes a re-epithelialization and regeneration of the skin. And just wrap it up in sterile dry gauze. For all burns, just as with a frostbite, they're going to be painful, significantly painful. So you want to make sure you provide them with appropriate pain control, and that you provide them with tetanus prophylaxis, because any cut in your skin, a burn is, opening of your skin can increase your risk of tetanus bacteria in there. And that's all I have for you guys today. Thank you for listening. If you have any questions, whether it's related to this lecture or not, feel free to reach out to me. And thanks for letting me do this.
Awesome, thanks Fatima. So yeah guys, we're gonna use a chat box for this. If you guys have any questions, just because I'm using a different template right now. So if you have any questions,